Dolman, and today I will be talking about dislocated shoulders. Alright, so some background. The shoulder is the most commonly dislocated joint in the body. In fact, about half of all dislocations seen in emergency rooms are shoulder dislocations. This is due to the shoulder's ability to move over 180 degrees in every axis. The shoulder is very susceptible to dislocation and under injuries because of this. The shoulder dislocations tend to occur more often in males than females. This is mostly because of the fact that males tend to play more contact sports like rugby, football, hockey, etc. than females do. 25 to 30% of shoulder dislocations are accompanied by related fractures, as I will cover more later on in my presentation. Alright, so what is a shoulder dislocation? A shoulder dislocation is when the head of the humerus is removed from the glenoid fossa. So you can see right here, this is the glenoid fossa. Right here, it's connected to the scapula, and then here's the head of the humerus. The glenoid fossa I'll cover more about later, but it contains about a ligament, and you'll see later on. Alright, so types of shoulder dislocations. There are three kinds. There is the anterior, which means forward, there's posterior, which means backwards, and inferior, which means downwards dislocations. So the anterior or forward dislocation accounts for 95 to 98% of all shoulder dislocations. It is caused by trauma to an outstretched arm, which could mean if I was going in for a tackle in one of my rugby games, if I hit someone with my arm in an incorrect position, it could pop out. Posterior or backwards dislocations are rare, so they only account for 2 to 4% of all shoulder dislocations. They can be caused by electric shock or seizures, which I'll talk about later. And they are also hard to notice at first with an X-ray. This is because posterior and anterior dislocations both appear the same from a straight-on view of an X-ray. This is because they both displace in a similar way, but they can only be noticed fully as if you look at them with respect to the shoulder, as in forward of the shoulder or behind the shoulder. This is incorrectly diagnosed about 50% of the time, so that's a pretty big chance. Inferior or downward dislocations, commonly referred to as luxato erecta. This is due to the extremely adducted position that they appear in, with the person's arm above their shoulder. They are also very rare. They are super rare. In fact, they only occur in about 1% or less of all shoulder dislocations. Although they are rare, they are also very damaging, or can be very damaging. They have the highest risk of damaging surrounding tendons and ligaments and blood vessels. This is because the humerus head is displaced downwards in these situations, which pushes it right into the hub of all these blood vessels, ligaments, and tendons, which is not a very good thing. All right, as you can see here, these are all the pictures of the different kinds of dislocations. All right, so causes of injury. There are two main kinds of injury. There's direct and indirect. I will break it down in between each different kind of dislocation. So for the anterior dislocation, it is caused by trauma to an outstretched arm, as I already said before. This trauma comes from the posterior, so it comes from the behind most of the time. This is why the shoulder is pushed out forwards. Posterior or backwards dislocations are occasionally caused by electric shock or seizures, as I said earlier. This is because the shock or relaxation of some of these muscles in the rotator cuff, which I'll cover later, cause an imbalance between the muscles in the shoulder, which therefore causes one side to pull it more, which pops out the shoulder. This can also be caused by trauma from the anterior side or forward side, so that causes the shoulder to pop out backwards. Inferior or downward dislocation is caused by hyperabduction. So for example, it would not happen all the time, but if I was diving into a pool and I was to land straight on my hands, it might push my shoulder down, which would cause an inferior dislocation. All right, so complications. As I said earlier, 25 to 30% of all shoulder dislocations are accompanied with a related fracture. Some of the examples of this is an acromion, a greater tuberosity, which is the site of where the rotator cuff muscles attach to the humerus. So some of these tendons can be damaged and such. Broken clavicle, which is a whole different kind of injury, but this can be related from the pressure that is put on the shoulder. Fractured humeral head, for example, my dad, when he had a shoulder dislocation, he fractured the humeral head and had to get surgery to remove it. There are also many more other kind of related fractures that could happen. Dead arm syndrome is one of the main symptoms that you will have when you have a dislocated shoulder. This is due to the auxiliary nerve being pinched, which makes it unfunctional. So it causes your arm to have no feeling, hence dead arm syndrome. Pain is a very, very big thing. Sometimes the pain might not be as bad until you pop the shoulder back in. This is also due to the auxiliary nerve again, but pain is a very key component of a shoulder dislocation. Once one shoulder dislocation has occurred, the person who've had it is very susceptible to another. I like to explain shoulder dislocations like an elastic band or a bouncy ball. It's physics rules. Once you stretch it, it never returns fully to its original state. It always has a bit less elasticity left. This is the same with the tendons and ligaments in the shoulder. Once it's been stretched out, aka popped out once, it will never be as tight as it was before, so therefore it is more susceptible to further pop outs or shoulder dislocations. Traumatic osteoarthritis is also very key. This is essentially pain that occurs after you've healed from the shoulder dislocation. Stiffness in the shoulder is also one of the big complications and can be quite annoying. All right, so muscle, ligaments, and tendons. There are many nerves, muscles, ligaments, everything around the shoulder, which is why it is a very important thing to deal with once you have a dislocation. So nerves. In 30% of cases of shoulder dislocations, the auxiliary nerve is damaged. This can also lead to some damage or unfunctionability of the deltoid because the auxiliary nerve supplies motor fibers to it. The suprascapular nerve is damaged, and in 22% of cases, the radial nerve is damaged, such as the rotator cuff. The rotator cuff is a group of four muscles that attach to the scapula and connect to the humerus through tendons, which then surround the humerus and the humerus head in a cuff-like formation, hence the name rotator cuff. These muscles are the teres minor, the infraspinatus, the supraspinatus, and the subscapularis. Another muscle is the deltoid. The deltoid is the largest and strongest muscle in the shoulder. The deltoid is sometimes injured because after a dislocation has occurred, it is the one that has to take over holding up and supporting the shoulder during dislocation. Although the shoulder cannot move, the deltoid is the one that is supporting it. So tendons. Some tendons that can be injured are all the tendons that connect the rotator cuff muscles to the actual humerus bone, and these are the same. The teres minor tendon, the infraspinatus tendon, the supraspinatus tendon, and the subscapularis tendon. Sorry for my pronunciation. Yeah. Some ligaments are the glenoid labrum. The glenoid labrum is a rubber-like cartilage where the humerus connects to the glenoid cavity. I talked about this earlier. It was that white substance in between the humeral head and the scapula. It cushions the shoulder into the actual socket and can be damaged when the shoulder is pushed in hard. Injured are the glenohumeral ligaments, or the GHL for short. And this is a group of ligaments, as you can see over here, that surround the shoulder, around where the rotator cuff does. They are the superior glenohumeral ligament, middle, and the inferior. Alright, so shoulder. Will it ever heal? So after sustaining a shoulder dislocation, in most cases your arm will heal within 4 to 12 weeks. But everyone is different, so this is not set in stone. In most cases, the shoulder joint is immobilized for around 4 weeks. This is because you want to ensure that your joint has ample time to heal properly. It is regained in the shoulder in about 3 weeks from the injury, but pain may accompany it for up to a year. The shoulder will heal, but is more susceptible to future dislocations, as I explained earlier with the rubber band metaphor. Some shoulder dislocations do require surgery to fix. This can lead to a longer recovery time. There are many exercises and strengthening techniques that you can do to regain the strength in your shoulder. It is crucial that the recovery is not rushed. The items should be worn to reduce the stress on the shoulder. Do not exercise if you feel pain. Stiffness is okay though, but pain is a sign of your body telling you to not do it. Alright, so for some exercise, the pendulum exercise. This exercise is for the early stages of recovery, and it is meant to help you mobilize your shoulder. So to do this, you should stand beside a bench or a table and put your uninjured arm on the table and have all of your weight on that arm or shoulder. And you rock forward with your feet and let your arm hang down like a rag doll and swing to and fro, forward and backwards, and then side to side. Your goal is to get 90 degrees all around motion. And your arm should be fully relaxed, no muscles involved. You're just trying to loosen up your shoulder. The next exercise is the internal medial shoulder rotation exercise. This exercise is meant to isolate and strengthen some muscles of the rotator cuff, which are all very commonly injured in shoulder dislocations. To start, you want to tie one side of a rubber exercise band to a stationary object such as a pole or like a table leg in the room you're exercising in. Then you want to put the elbow of your dislocated shoulder arm against the side of your body with your fist and forearm at a 90-degree angle from your bicep. You want to extend your arm out away from your body with the other end of the bungee or exercise cord in your hand and slowly pull it in towards your body and then back out. You want to maintain it slow, and you want to make sure that you keep your arm attached to your body because that way you isolate the rotator cuff muscles. Here are all my references, and thank you for watching. Have a nice day.